Good morning all. Today I'll discuss about thyroid eye disease. Myself Dr. Bhuwana, senior resident from Department of Ophthalmology. Thyroid eye disease is associated with the disease of the thyroid gland, otherwise known as thyroid associated ophthalmopathy. Most commonly it occurs in hyperthyroid in 80% of the cases. In 10% it can occur in hypothyroid Hashimoto's disease. In 10% it can occur in euthyroid as well. Graves' disease is the most important cause of thyroid eye disease. It is autoimmune in origin. Excess secretion of thyroid hormone results in this condition occurs between 40s and 50s age group with female preponderance of 8:1. Major risk factors are smoking, exposure to radioactive iodine and thyroid hormone imbalance. The main pathology behind this disease is activated T cells infiltrating the orbital content, which stimulates the fibroblasts to produce glycosaminoglycans. This glycosaminoglycans causes excessive imbibition of water, leading to enlargement of extraocular muscles, cellular infiltration of interstitial tissue, leading to proliferation of orbital fat and connective tissue. This image shows the pathology where the thyroid stimulating immunoglobulin act on the orbital fibroblast producing differentiation, proliferation, glycosaminoglycan secretion leading to inflammation of the extraocular muscles with expansion and inflammation. This is a CT image of the orbit of the axial and coronal section on the right side showing enlargement of extraocular muscles. The stimulated fibroblasts causing the muscle to swell. It may swell up to 8 times. These swollen muscle will occupy the orbital apex and compress the optic nerve at the apex of the orbit, which can cause optic neuropathy. And these swollen muscle can cause forward protrusion of the globe leading to proptosis. So the eyelids do not cover well and dry out the eyes causing exposure keratopathy. Histologically, there will be lymphocytes, plasma cells, macrophages, mast cells which infiltrate the extraocular muscles, fat and connective tissue in later stages causing degeneration of muscle fibers leading to fibrosis of the involved muscle. This fibrosis of the muscle causes extraocular motility defect. The most common defect in thyroid eye disease is the elevation deficit, which is shown in this image. The order of muscle involvement will be inferior rectus, medial rectus, superior rectus followed by lateral rectus. The two stages are active congestive or inflammatory stage and the fibrotic stage. So in inflammatory stage, it is related to inflammatory symptoms such as chemosis, conjunctival ingestion, muscle hypertrophy and periorbital edema. It has a waxing and waning course. In fibrotic stage occurs after the active stage has passed and it is characterized by painless ocular motility impairment due to muscle fibrosis. So these are the signs of thyroid associated ophthalmopathy. Dalrymple sign caused due to eyelid retraction. Von Graffi sign, lid lag of upper lid on down gaze. Enroth sign, edema of the lower lid. Gifford sign, difficulty in eversion of the upper lid. Mobius sign, lack of convergence. Stellwag sign, incomplete and infrequent blinking. The main clinical features are soft tissue involvement, eyelid retraction, proptosis, optic neuropathy in around 5 to 6% of the cases, exposure keratopathy and eye movement restriction. Soft tissue involvement presents with symptoms like variable grittiness or foreign body sensation, photophobia and lacrimation of eyes. Signs will be periorbital and lid swelling, conjunctival hyperemia, which is a sensitive sign of disease activity. Chemosis, which is edema of the conjunctiva. In severe cases, it may even lead to prolapse of the conjunctival tissues. This image shows soft tissue involvement. The first image is the periorbital edema associated with chemosis and lid swelling. The second is the conjunctival hyperemia, which occurs at the insertion of the horizontal recti muscle. And the third image shows chemosis. Fourth image shows associated superior limbic keratoconjunctivitis. The treatment of soft tissue involvement is usually conservative, like topical lubricants, artificial tears and ointment, which reduces the inflammation and reduces the irritation, elevating the head end of the patient during sleep, and taping of the eyelids at night may be useful for mild exposure keratopathy. Eyelid retraction is a sensitive sign of thyroid eye disease. It occurs in 50% of the patient. It may be due to contraction of the levator muscle by fibrosis or excessive action of Muller's muscle due to the high levels of thyroid hormone. Treatment is spontaneous resolution. Associated hyperthyroidism should be treated. Surgeries are indicated when eyelid retraction and thyroid status is stable. Commonly performed surgery for eyelid retraction is Mullerectomy and LPS recession. Proptosis. Proptosis is usually axial in thyroid eye disease. It can be unilateral or bilateral. It can be symmetrical or asymmetrical. Thyroid eye disease is the most common cause for both unilateral and bilateral cases of proptosis in adults. It is uninfluenced by the treatment of hypothyroidism and it will be permanent in nearly 70% of the cases. Severe proptosis prevents adequate lid closure and may lead to exposure keratopathy and corneal ulceration. Treatment involves systemic steroids to reduce inflammation, low-dose radiotherapy. In severe cases, surgical decompression is needed where one or more walls of the orbit are removed, causing increase in space and relief of proptosis. In extreme cases, even all four walls of the orbit may be removed. Optic neuropathy is a serious complication affecting about 5 to 6% of the thyroid ophthalmopathy patient. It is caused due to direct compression of the optic nerve or its blood supply by the enlarged and congested recti muscles at the orbital apex. It may occur even in the absence of proptosis. It causes severe visual impairment, but it is preventable. Early sign is decreased color vision, progressive impairment of visual acuity, visual defects usually central scotomas and optic atrophy in chronic advanced cases. Treatment of optic neuropathy depends upon the severity. In initial stages, systemic steroids are indicated with radiotherapy and orbital decompression is considered if above is ineffective or optic nerve is severely involved. Ocular motility problems, it occurs between 30 to 50% of dysthyroid patient. Diplopia may be transient, but in many cases it is permanent. Ocular motility is restricted by edema in infiltrative stage and fibrosis during the fibrotic phase. Defect in elevation is the most common deficit due to the involvement of inferior rectus muscle. Surgery is usually considered if the diplopia is in primary gaze or in reading position. Diplopia must have been stable for about 6 months. Treatment is by muscle surgery with the aim of producing binocular vision while looking forward and good cosmetic result. Botulinum toxin injection to relax the muscle may be useful in selected cases. Thank you.